Dr. Mike Levine, and I don't know where he is. Who was the founding director of CVD. CVD was the first organized research center at the University of Maryland and really remains unique among academic medical centers for our full range of work from discovery all the way up to delivery and impact, as you just saw. So again, everything that you've heard and will hear is Mike's legacy. So thank you, Mike. I'd like to bring up the three panelists, and we're going to do this in a similar fashion to how Dr. Gerald moderated earlier today, where I will introduce the three panelists, and then they will come up one at a time to each give a part of this presentation. So Dr. Miriam Laufer, walking up first, is the professor of pediatrics and the associate director for malaria research at CVD. And Dr. Karen Kotloff has many titles. She's the division head of pediatric infectious diseases and the associate director for clinical research at CVD. And then Dr. Mamby Keita, who joins us from CVD-Mali, where he is the director of epidemiologic studies. And Mamby, I believe you're first.
Thank you. I think it was expected that after the golden buzzer, I will have stuff time, but somebody promised me to have a funny face before I start after summer. So but I cannot see him. Thank you. It's an honor, a privilege to be here to share experience of CVD-Mali in terms of epidemiological study. The epidemiology department have been created formally in 2015, and we have more than 70 staff, medical doctors, nurses, midwives, sociologists, anthropologists, and social workers in this department. We are doing hospital-based surveillance and field epidemiology. And currently we have some completed and ongoing study, but the backbone, which has been mentioned by Professor Samba, the invasive bacterial infection surveillance in the main pediatric hospital is still ongoing. We had GEMS, Globally Enteric Multi-Center Study, and the VIDA study after the Rota vaccine introduction to study diarrhea epidemiology. And CVD since 2009 is the National Referral Center for Influenza in Mali, and we are conducting national influenza surveillance through Sentinel site. So we are also, after the Rota vaccine introduction, we are doing antisusception surveillance. And we complete the pneumonia epidemiology study called PERCH. Now we have CHAMPS, which will be the focus of my talk. CHAMPS stands for Child Health and Mortality Prevention Surveillance. So this surveillance program is implemented in 7 countries in sub-Saharan Africa and South Asia, in Mali, Ethiopia, Kenya, Mozambique, South Africa, and Sierra Leone recently. CHAMP's journey starts with the socio-behavioral science. So we, first of all, the objective is to identify the cause of death through minimal invasive tissue sampling. But before we start anything, we have to know the feasibility of the study through socio-behavioral science. We went to our community to know how this study will be accepted, what is their perception toward the study. And we implement the mortality surveillance network with community relay, imam, cemetery guard, community leaders to notify death so that we can contact the family and propose enrollment to know the cause of death. We have also the pregnancy surveillance with midwives who go door to door to identify pregnant women and sensitize them about danger signs they may experience during pregnancy and route them to do early ANC. So the next step of CHAMPS is when death is identified within the community, we propose enrollment. After obtaining consent, we take specimen, clinical data and verbal autopsy data, clinical microbiology data, histology locally and at CDC, all together are given to the DeCoDe panel, which is a panel of experts to review the data and identify the final cause of death. And the main objective is to use data for action, inform politic, health authority in the country to reduce child mortality. So the myths compared to the full autopsy is more acceptable because with the full, you do open the head, but this is really hardly accepted compared to myth, which is well accepted by our community. We take blood, non-tissue sample, blood, CSF, and POP, and stool sample, and also some tissue sample from the liver, lung, heart, brain, and bone marrow for histology purpose. So all the data, demographic, myth data, clinical abstraction, verbal autopsy, pathology results are given to the panel of experts, the DeCoDe. DeCoDe stands for Determination of Cause of Death. So they will review and assign the cause of death. And if there are underlying cause, immediate cause, underlying cause, and maternal cause of death. So this, I'm going to present some preliminary cause of death from the first 90 cases. We are about more than 115 deaths enrolled in the myth. And the underlying cause is defined as a condition that triggers the event leading to the death. So we put the case by age. We split them by age group. For the stillbirth and newborn, less than 1 days, 24 hours. The most stillbirth and newborn deaths are related to obstetrical complications. Regarding the age group 1 to 28 days, in neonate birth defect, prematurity, and still obstetrical complications continue to be predominant, but infectious are becoming important in this age group as underlying and immediate cause of death. So going forward, for the 12 to 59-month-old, in this age group, infections are predominant, including we have 2 cases of measles and 2 cases of malaria in this age group. So as I said, data to action. The 2 measles cases indicate that we have a portion of our population that are susceptible, and the 2 cases also support the importance of having measles vaccine mass campaign to have good coverage. So this campaign is just ending now. So outcome related to neonatal respiratory distress also could be improved with the CPAP, bubble CPAP. So with thanks to God, we have with private donor equipped neonatal units in hospital in Bamako that are helping children with respiratory distress to improve quickly. We identify poor antenatal care in terms of provision and health-seeking behaviors. So we need to train the personnel, and also to sensitize community on the importance of completing antenatal care visit, and also to follow the advices. Also, we need to share the DeCoDe results with professional society, OB society, pediatric society, to share our results, and then it will help them to direct the routine practices. We also identify poor medical transport system. CHAMPS data and others that it can be used to justify the need for improvement of the transportation system in our country. So regarding the publication, I will not go in detail. You will just need to go to on PubMed and type SOW space SO or the next speaker. But this is our field worker here. One of the field work not only on Ebola, but also taking measurement. That's all. Thank you. Thank everyone, the organizer, CVD, UMB, WHO, CDC, Mali government, MOH, study population. Thank you.
Good afternoon. So I really, truly enjoyed this morning's talks and understanding the tremendous impact that these HIV implementation programs are having. There are differences in the type of work that our group and that group does, but there are also some very strong similarities, including our desire to find information that leads to action and has an impact, and the challenges, which means getting sustained funding when you're working on programs that are completely grant funded. So here on this map is the footprint of where people who work at the CVD do global health work. And you can see that it really crosses several continents and is quite broad. CVD-Mali is our flagship organization, but we also work in many other places. And the model that we use, and this is really a model that was inspired first by Mike Levine with the Hib story, and that is to gain evidence that leads us to action such as testing and intervention, and then measuring its impact so that you can really be certain that what you have done has made a public health difference. And that's really what we all want to do. A good example of how this model comes into action is the typhoid vaccine work. And there are projects that are being led by Kathleen Neuzil that I'll talk about first, and that's TYVAC. And then I'll also mention the typhoid work that Mike Levine has been doing. So for those of you who are not typhoid files, typhoid is a substantial public health problem. It affects the most impoverished people in the world and causes 11 million cases as an estimate and more than 116,000 deaths each year. And outbreaks of typhoid continue. The availability of effective treatments is being compromised by increasing antimicrobial resistance, and improvements in water and sanitation lag in many parts of the world. And so vaccines seem to be a very good way of controlling this infection. And we've been fortunate that new typhoid conjugate vaccines are now licensed and recommended, and these should overcome the challenges that have been that have been faced, that have impeded the uptake of earlier typhoid vaccines, because conjugate vaccines are immunogenic in children under the age of 2, and so they can be administered through routine immunization. They generally have longer lasting protection, and prior vaccines of this nature were shown to be efficacious in field trials. But the current vaccine, the TYVAC vaccine, has not been tested. And this is really a granular look at what evidence action impact really means. And this is the structure of Kathy's TYVAC study. And basically, if you start on the right, I don't know if this shows, does this show up? Yeah. Okay, so there have been epidemiologic studies that have characterized the burden of disease, creating evidence to support typhoid vaccine introduction, plus some vaccine experience. And those data were presented to WHO and resulted in WHO making policy recommendations for the use of these vaccines in high-risk populations. At the same time, or shortly thereafter, Gavi agreed to provide funding for the recommended use, and then the manufacturer of the vaccine received pre-qualification, which enabled the vaccine to be given for use in countries. At the same time, several efficacy and effectiveness studies have been designed to actually measure whether this vaccine is safe, immunogenic, has a public health impact, is efficacious, and those data will help to support an introduction case. And at the same time, there are staff that are part of this study who are working to facilitate country willingness and readiness to introduce, and local uptake and sustainability. So this is really a multifaceted approach that is happening all within a single umbrella. The clinical trials that are going on are in Africa and Asia. So there is a effectiveness and individually randomized trial in Malawi, and Malawi is here, sorry, and in Burkina Faso, and also in Nepal. And then there is a trial in Bangladesh that's a cluster randomized trial. And under a separate umbrella, there are trials in India that are being conducted. And these trials, as I said, will help to inform decision making. So now stepping back to other activities that occur at the CVD that follow the model that we've been discussing, here are a number of examples. So we talked already, Samba already talked about the studies that we did of invasive bacterial infections and how they have led to vaccine trials and measuring efficacy, and then post-introduction burden of disease study to understand what the impact is. We did studies of group A strep in Mali, and we looked to see whether it was an important cause of pharyngitis, and if so, what were the antigenic types that were important, so that could inform vaccine design. We also looked at the rheumatic heart disease prevalence, because that's the dreaded complication, or one of the dreaded complications of group A strep. And then we conducted a phase 1 trial, which was in itself a big step, because group A strep vaccines there was a lot of caution about testing them for fear that there could be antigenic mimicry that could result in unacceptable side effects. And so that's kind of where we are right now with that vaccine. The commercial development has been impeded, but we've made some progress, and we're hoping in the future there will be more. Mamby mentioned the GEM study of the incidence and etiology of diarrheal disease, and we showed that the major cause of moderate to severe diarrhea was rotavirus. At the same time, Kathy conducted a rotavirus vaccine efficacy trial, and these data supported introduction of rotavirus vaccine, and we're now conducting the VITA study to measure the impact of that. In addition, Gates funded a study called ABCD, or Antibiotics for Severe Diarrhea in Children, to try to combat the effects of non-viral diarrhea. The Perch pneumonia study showed us in Mali that our weak infrastructure was contributing to a very high pneumonia-associated mortality. And with the help of Adnan Buddha, we are trying to introduce bubble CPAP into that major children's hospital that Samba talked about. The CHAMP study is going to tell us more about the causes of diarrheal disease, as Mamby mentioned, and the Santé study, which I'll mention briefly, will help us to give an intervention that may decrease child mortality. And then finally, Mike Levine, who has really dedicated his life to understanding the epidemiology and control and vaccine development of typhoid fever, is now conducting typhoid surveillance and transmission studies and studies of carriage, hoping to eliminate typhoid from the island of Samoa and look at the impact of treatment of chronic carriers, and those results are in progress. So just to end briefly with the Santé study, Santé has a kind of acronym that stretches it a bit, but the English translation is to save lives with azithromycin by treating pregnant women and infants. And this study has the primary aim of determining whether azithromycin given to pregnant women at routine antenatal care and during labor reduces the composite outcome of stillbirths and infant mortality compared to placebo, and to determine whether azithromycin given to babies during their first and third infant DPT immunization reduces mortality between 6 weeks and 12 months of age compared to placebo. If you look here, we're doing this study in Sakasa, which is a rural area, and Bamako, and these are very high mortality areas in the world. This is the design of the primary cohort that addresses the primary aims. So we will enroll 34,000 women to get 28,000 analyzable infants. And these are pregnant women in their second or third trimester, and they'll receive either azithromycin or placebo at the 2 antenatal care visits and during labor, and their infants will be randomized to receive either azithromycin or placebo at their vaccination visits. And the same will occur in the placebo group. So it's a 2x2 factorial design. And we're very hopeful that this will have an impact on the high mortality in Mali, but we'll have to wait to see. So I have a lot of thanks. This is mentioning the CVD-Mali team that's involved in Santé and the CVD team and other collaborators involved in Santé. But I do have to say that many people in this audience are members of the CVD and CVD-Mali, and there is a diverse portfolio of very important studies that I wasn't able to mention here. So I would like for the members of CVD-Mali and CVD to stand up for a round of applause. Thanks.
Thanks very much. I am here representing the malaria research program of the CVD, and I know I stand between you and lunch, and I was going to say, at the risk of making everyone hungrier, I don't have time to present much of anything. I'm giving you tapas, little bits and pieces of some of the work that we do. We are one of the largest and most interdisciplinary malaria research programs in the country. And for those of you who are interested in anything that I bring up, or any other areas that seem relevant, I invite you to talk to me, to talk to Dr. Don Matanga, who's one of our main collaborators, or any other members of the malaria research program who are here. So, like what Karen said, we also sort of focus on evidence, action, and impact. I like to say that what we do in the malaria research program is use the best available science to answer the key public health challenges. And the key public health challenge in malaria is to decrease the burden of infection and lead to elimination and eradication. The areas that we cover include vaccine development, pathogenesis and immunology, antimalarials, diagnostics and surveillance, and transmission. So I'll give you a few flavors of those. As we talk about some of the places where we work, we do a lot of work here in Baltimore, in our laboratory, and also in people who we give malaria to. So I'll tell you about that at the end. Our key field sites are Mali and Malawi, and we also work closely with collaborators in Burkina Faso and in several countries in Southeast Asia. So first, I'm going to talk about drug resistance. This was sort of the first area of research of our malaria research program that has been in existence for over 20 years. So one of the things we do extraordinarily well at the University of Maryland in basic science is we are able to sequence the entire Plasmodium falciparum genome. It is not an easy task because each Plasmodium falciparum genome is quite different from others. And we use that capacity along with our close collaborations with people in the field to be able to answer these key public health questions. For example, what is the basis of resistance to antimalarial drugs? And this is work that's led in our group primarily by Shannon Takala-Harrison, and we used genome-wide association studies, which is the new way to use genomics, to identify the molecular basis of artemisinin resistance. And we wanted to know, did artemisinin resistance come up one time and spread throughout Southeast Asia, or did it come up multiple times? And we used genomics to say that the answer to that was yes and yes. In some cases, it arose independently, and in some cases, it arose and spread to different places, as you can see by the different colors on this diagram. And then we also sort of like to think of ourselves as people who think outside the box. So when we're talking about drug resistance, the first drug that was used to treat malaria, as many of you know, was chloroquine. And chloroquine resistance emerged just a limited number of times. It emerged, interestingly enough, in Southeast Asia and spread to sub-Saharan Africa. And the reason that we started working in Malawi was because Malawi was the first country to stop using chloroquine for the treatment of malaria because of widespread drug resistance. And what we found about 12 or 15 years after Malawi stopped using chloroquine is that all the malaria parasites now in Malawi are chloroquine susceptible. So chloroquine resistance has disappeared. And this has been documented now throughout many parts of sub-Saharan Africa, not everywhere, but Zambia, it's happening in Mozambique, Tanzania, Uganda, et cetera. So we now have a new research program looking at different uses for chloroquine for malaria control and prevention. Some of our work has led to interesting new discoveries. So Dawn mentioned the International Center of Excellence in Malaria Research, where for the first 7 years, we did, among other things, several cross-sectional studies looking at the burden of malaria. And we expected, like everybody thinks about malaria, that the burden would be highest in children under the age of 5. Well, as it turns out, the prevalence of malaria infection is actually highest in school-age children, children over the age of 5 and under the age of 15. And then we thought, well, how important is this from a public health perspective? We know that this group of children are not dying from malaria. It's really children under 5 who die of malaria. So we were wondering whether this group of humans who have malaria infection were responsible for transmitting malaria from person to mosquito. And what we found was that if they had malaria infection, school-age children also were more likely to carry the type of malaria parasites that are transmissible to mosquitoes. So they're more likely to be a source of malaria transmission. And how do we stop malaria transmission in sub-Saharan Africa? As Don mentioned, we use bed nets. And as it turns out in this population, school-age children are the least likely to sleep under bed nets compared to younger children and adults, which has led us down 2 interesting paths. One is to, in more depth, really try to understand, are these kids really the sources of malaria transmission, and understand what populations should be targeted for future interventions. And at the same time, we're extremely interested in malaria in in developing programs for school-aged children. So there's a variety of options for ways to either prevent or treat malaria infection in this group. And we're also quite interested in developing this platform of school-based interventions, not just for malaria, but for other things, for health education, for vaccination, and for routine health care. So speaking of vaccines, our major activity at the CVD Malaria Research Program is vaccine development. And one of the things that we uniquely do at the University of Maryland is we have an entire suite set up to do human challenges of malaria infection. So for those of you who come from Africa, I know it will seem crazy, but there are people who walk into our laboratory so we can give them malaria. We do diagnose them quite quickly before they get sick. But so in order to trial malaria vaccines, there's two things you can do. You can give them to people who live in malaria endemic countries and send them out and see if they get malaria or not. There's a lot of factors that will go into that. Or you can give people the vaccine and then actually know that you're giving them malaria, where we have malaria-infected mosquitoes and they get a certain number of bites, or we give the sporozoites via injection, and we see whether or not people get malaria, and we can tell that way whether or not the vaccines work. We do a lot of the vaccine trials with the whole organism irradiated sporozoa vaccine. We also do recombinant vaccines, and we're uniquely set up to do these challenge trials. In addition to our trials in the United States, we've helped to support several research centers throughout Africa to conduct both drug trials and predominantly malaria vaccine trials. So not only do we support these types of studies done in this tightly regulated, easily controlled, very small studies that we can do here in the US, but we've supported laboratories throughout the world to conduct FDA-regulated, high-quality clinical trials throughout the world. And then bringing it all together, and this slide comes from one of our Malian colleagues who's now a faculty here at the CVD. We'd like to bring together genomics, what we know about malaria in the field, and everything we know about immunology and protein expression to develop a new way to think about developing a highly effective malaria vaccine that takes into account all of these factors that are so critically important, and with the hopes that we will develop a highly effective malaria vaccine in the future. And that's all I have for you today. Oh, sorry, that's not all I have for you today. So one thing that the CVD is very much committed to, and I wanted to make sure I emphasize in this crowd, was the training of the next generation of investigators. And we do this both through training our investigators here at the University of Maryland, as well as colleagues throughout the world. We currently have a Fogarty International Center grant that Don mentioned with researchers from Malawi, and our top writers, our latest edition from Cameroon. And we've had Fogarty grants in the past with Mali, and we are submitting another one right now. We have training grants for US-based trainees who are studying vaccinology, and we've had most people actually work on projects that at least have some global health component. We support local ministry national malaria control programs to conduct some of their surveillance, some of the molecular analysis from their surveillance studies at our laboratory. And of course, we have funding for individual trainees and mentors as they've been able to apply. So here you see pictures of some of our trainees, and in the middle is a picture from the American Society of Tropical Medicine with many of our trainees now. We are affectionately known at the graduate school as the Malaria Mafia, as you can tell because they're all sitting in the very back row there. So that is all I have to say for you today. Thank you.